everyone. I'm Erika. I'm the Community Outreach Specialist with HD Reach, and I have my co-host back. Who are
Lauren
you?
Holder. Hi.
With
So
Help
glad
for
to be
HD
here.
Podcast. So happy that you're here with us.
Yeah, thanks for
And
having me.
it just feels good to be back together doing these.
I know.
But I am so excited. And I feel like I start all these videos. I'm always so excited, but I am extra excited. Um, we have Shivani Borah, who is a previous a supervisor of mine when I was in hospice. And I get to like kind of reflect a little bit where I'm like, I started hospice, I think it was like uh, 2017, and I worked a couple years in South Carolina, and then I transferred into North Carolina, and Shivani got to be my supervisor. And I learned the basics and really started out as a social worker in hospice. And then with transitions life care was where I really started thriving with like just my professional skills and under Shivani. So I'm so excited that she's here today. And I'm grateful to have this conversation around hospice and hospice care. So Shivani, could you tell them a little bit more about yourself?
Absolutely. Well, I'm excited to talk about hospice, which sounds like, a weird thing to say. But I think, it's such an important topic. I am a clinical social worker by degree and by training. I have been a social worker for 23 years and have been at our hospice, Transitions Life Care, for 18 years. And for the majority of that time, I've been a field social worker. So had visited folks in the home or in facilities, and I've been a supervisor for the past 4 years. So got the pleasure of really helping Erika find her roots in the work that she's doing.
Yeah, that's what, it helps me. Everything that I do today is rooted in my experience. And so I also kind of, uh, say, just like Shivani just said, it's really weird to say we're excited to talk about hospice, but it is something that is super important. And we want to make sure that the education is out there for families if that is the path that you choose or you need to go through, and make sure that you're getting the correct information around what this is. Um, so Shivani, what is hospice?
So hospice is a philosophy, I think, to start with. It is the philosophy behind hospice care is comfort care, and it's supporting people through a variety of ways, and it's all through interdisciplinary team members. We have doctors, nurse practitioners, nurses, social workers, volunteers, spiritual care aides. Uh, we're all really focused on making sure that the patient, the person with the disease, has symptom management, and the family or the friends who are supporting that person have the emotional support, the spiritual support, not just for the family, obviously, but also for the patient. So it's really encompassing care that really focuses on what can we do to bring about quality of life.
And how is it different from, because a lot of times we hear about palliative care versus hospice. So how is it different from palliative care?
So palliative care also focuses on symptom management for life-limiting illnesses. However, palliative care, you're still able to do some of the things that, treatment or what they might call curative or aggressive care. So people who engage palliative care may still get a certain type of injection or certain type of medication that hospice wouldn't necessarily cover. Or, if you were thinking about cancer, you might still be able to have chemo or radiation and engage palliative care. But the purpose is the same, meaning managing symptoms while you're coping with this illness.
So would you, I guess, go like initially maybe start with palliative care and then tend to like when do you engage hospice um, versus palliative care?
Um, well, hospice is engaged. Not everyone who comes to hospice goes through palliative care first.
Right.
We have a very robust palliative care program here at Transitions. And nurse practitioners usually will refer someone to hospice when they see that the disease trajectory um, is getting to the point where the prognosis is about 6 months or less. And that definition is not ours. It's really set forth by Medicare, the Centers for Medicare and Medicaid Services, and all other insurances kind of follow those directions. So 6 months or less, in the best estimation of a physician or nurse practitioner, that's when hospice can be engaged. It's not to say that, you know, we have folks who are on services for a year or more, and we're able to keep them on services because the decline is kind of still happening.
Right.
They're still losing weight, they're still pocketing food. Those kinds of things, will help us justify keeping someone on services beyond that 6-month mark.
I remember that was when I got into hospice, that was very unique, where it was like, you wanted to document, I guess, in a way, not successes and other areas of social work, but when it comes to hospice, you really wanted to focus on what symptoms were we still needing to be there to help manage. Like, we really wanted to find every little detail so that that individual could remain and get hospice services, like continue to get hospice services.
Mhm. And we're required by the insurance, the CMS,
Mhm.
Centers for Medicare and Medicaid Services. We're required to document those changes to be able to justify keeping someone on services. So it's not, if hospice ever talks about graduation from hospice, it's not because we're, not wanting to provide the care. It's because we're kind of forced to document, is there stability? Is someone getting a little bit better, or is there a continued decline? We have
Mhm.
to answer to those regulations.
Yeah.
So for those who enter hospice care, it's, I guess, obviously, like, you'll do the actual physical assessments and things, but it's okay to be honest with, if there's falls, if there's certain things that are happening within the home. Like, these are documented things that essentially help a person continue to receive this care.
Yeah, and I don't know if you're ready to talk about this now, but we can talk about some of the signs or the symptoms that we're,
Absolutely.
when it's time to think about a
Mhm.
potential referral to hospice.
Love that.
And it's when someone has had documented weight loss. Maybe you're noticing that their clothes are baggier than they used to be. Because sometimes it's hard at certain stages of certain diseases to weigh someone, right? So when their clothes are getting baggier, when you're noticing, the ribs or the bones protruding, the clavicles, or even what we call temporal wasting, where the fat in our faces begins to sort of wear down, and you see the bone structure more. Um, People who are having trouble swallowing effectively. So when they drink or eat something, you may notice coughing. Um, or if they're holding or pocketing food in their mouth, that can also be a sign that, yeah, I think we need to engage. We need to engage hospice. Um, Frequent hospitalizations, frequent infections like pneumonias. Sometimes they're caused by aspiration, meaning swallowing incorrectly down into the lungs. Um, Bed sores, skin breakdown, sometimes even severe agitation. So all of that together can paint a picture that it's time to engage hospice. And we're always open to evaluating. So there's no harm in calling and saying, I'm not sure if we're there, but could someone tell me? Could someone come out and evaluate my loved one to see if it's time?
So, my understanding, there's three different types of services. So, like for my dad, we did hospice in place at the hospital
Mhm,
because he did not have very long. And so we were moved to palliative care unit, and then we did hospice in place for him. For my grandfather, we are doing hospice at home,
mhm.
and we have the nurses come into the home and do everything there. And then there's actually at a hospice facility.
Mhm.
Is that right? Are those the three?
Those are there's one more. We
Oh,
forgot
okay.
facilities, nursing facilities or
Oh,
assisted
okay.
living facilities. So what you're talking about in the hospital settings, that's called general inpatient level of care, or GIP. And it's where someone, it may not be safe to move them out of that setting, and they need symptom management. I think in our area here in Wake County, there isn't a unit in the hospital anymore. Rex Hospital used to have that up on the fifth floor way long ago. But uh, sometimes anyone can be in a various, like a regular hospital bed, and still be general inpatient or GIP. We serve folks who are in assisted living facilities, who are in nursing facilities. We serve the majority of folks at home. They're still living with their loved ones at home, and we provide care intermittently in the home. And we do have the hospice home. Uh, those have similar. The hospice home has similar requirements as a hospital for general inpatient. There has to be a symptom that we're managing. The majority of the folks that come to our hospice center are only there for a few days. Sometimes we get a symptom managed, and then they go back home, or they go back to their facility, or they are really at the very end of their life, and in the same space that we're managing a symptom, their disease is progressing to the point where it's the end. So those are the four usual spaces that we see folks receiving hospice services.
Now I want to shed light a little bit on the hospice care home.
Mhm.
So I know that, some hospices will have them, some will not. Some may utilize, they may have to contract out, but with Transitions Hospice Care Home and with some hospice care homes I've been in, um, there's this incredible peaceful tranquility. Like, this is hospice owned staff, right? This is employed by Transitions. These are staff members that are employed in end of life and dying. And there's something so special with everybody has their individual rooms, and volunteers bring food for the families. So I want to kind of just highlight that hospice care homes where, it may be like this like knee jerk, that's where my loved one will die, which, like Shivani said, they may not. Like, that may be something where their symptoms are managed so that they can get back home. But also knowing that if your hospice has a hospice care home available, check it out, look into it. That might be a beautiful option if needed, or it may be kind of like an end goal that, this is a backup, and I know that this space is ready and equipped to love on and take care of my loved one.
That's right. And I think, the staff that works at the hospice center, whether it's ours or someone else's, their training is on managing end of life symptoms. And um, we get into this work, hospice work, because it's a calling for most of us, and that shows. Um, and I think the confusion sometimes folks have is that my loved one can go to a hospice home and stay for weeks or stay for months. And unfortunately, that's not the way it's set up to work. Our any hospice facility almost doesn't have the ability to become like a long-term care center or long-term care placement. So we provide tremendous care, I think, to folks who need the symptom management and are, um, really nearing that end of life. Um,
There's something that you just said, and I really want to stress it. It's the fact that the staff with hospice is trained in end of life. Like, these are not your typical nurses or anything. These are people who literally deal with this all the time. They receive special training for this. They know exactly what to look for. These are experts, right? And so for those of us who are going through taking care of somebody at end of life, and we're sitting there going, oh my gosh, well, I don't know what I'm looking at. I don't know if you know, if something that I'm looking at is actually significant or not.
mhm.
This is where the hospice team is so valuable, because they know exactly what they're looking at and can come in and help you even with position management, right? Like putting pillows in the right place, because they know like what's the most comfortable. We had a nurse who did that, who literally was like, oh, well, I stick pillows here, here, here. And she kept coming back through the whole night, just repositioning and everything with my dad. And it was amazing to see, because I wouldn't have thought of it. Would have never thought of it. And she just knew things like that.
Yeah. And it's, I think, we all learn from each other. I've picked up so much over the years from nurses, aides, spiritual care counselors that, let's cut the shirt up the back. And that way you don't have to, if your loved one is real tight, up here, we don't have to stretch their arm to get them clothed again. So there's all sorts of tricks. And, um, social workers, spiritual care counselors, even the volunteers and aides, they are really looking at a person as a whole person, and also trained to look at, okay, this agitation may actually be about pain. Um, I see that your loved one isn't able to speak to us anymore, but this furrow in the brow, this this restlessness that we're seeing, it may not be, it may be best supported by pain medicine or something that would help them be more comfortable positioning even. Yeah.
That's that right there is a huge thing for me. And is, I think people at the end of life, the family members at the end of life, watching their loved one, the pain management, it's scary, it's terrifying. You don't know enough about it. And so you don't necessarily know the cues. And um, and that's something we've been, dealing with. And because of going through this with my dad, I know the cues. But seeing my family struggle in this area and just having the nurses explain to them, like, well, no, like you just said, this furrowing here, or this is an indication of agitation, but it's probably related to pain, and then show how they think it's related to pain, and that really helps, because most people don't realize it, especially because our loved ones are nonverbal at the end. They can't communicate.
Mhm. Yeah.
I think of my grandfather when he was put on hospice within a hospital, in a hospital setting, and he started moving, and he hadn't been very responsive for a while. He had infection, there's a lot going on there. It was his time, and he would be pissed if he knew he was still alive in that state. He was that kind of guy that's like, don't you let me do it. Don't you let me be in diapers, or briefs. But he started moving and shaking and like moving, and then the furrowing of the brow. And we had so many family members in there that, the visits were a little bit infrequent, but by like the nurses here and there, but because we just had so many people, and I had to keep talking, like, let's give Gramps some space. Let's give some time to go in the next room. Gramps needs to relax. But when that happened, I mean, I obviously I react very differently when I was in the profession, but with my own family, I'm like, you guys, in their minds, he's trying to wake up and talk to everyone.
Right.
And in my mind, I'm going,
You're agitating.
I'm about to go get I have to get him some more medications.
Yep.
And you guys need to give him some room to breathe.
Yes.
But that was also a very big shell shock moment for a lot of people too, to switch that. Is he really trying to wake up and be there and reacting to us versus is this a pain response?
Or even something like terminal agitation.
Yeah.
Some diseases have something called terminal agitation where for a reason we're not really sure of, there's so much about death that is still a mystery. Some people have something called terminal agitation where even if pain is addressed, they can still be agitated or restless. And then we might move to a different type of medication in conjunction with the pain medicine to help just calm them. And none of the medications that we utilize in palliative care, hospice care, none of it hastens the disease process or makes it move any faster. For one, it's illegal here in North Carolina. But two, it's small amounts of medication meant to address the symptom, not change the trajectory of the illness. Because the natural hospice follows the naturally dying process. We just are supporting the body as it's happening.
Yeah. And that's key right there, right? Like that. I think there are a lot of myths that people believe about pain management and hospice, specifically morphine and it hastening death, which is absolutely not true. But everybody, or not everybody, but there are a lot of people who believe that. And then they associate that with hospice. And the reality is it's not hospice. Your loved one's already dying. And hospice is there to kind of help comfort and provide some symptom management, as you said. But they're dying. Like that's where they're headed. It's not making it go any faster. So.
Yeah. And for certain disease processes, I know this is about HD, but even certain disease processes like COPD, which is a lung disease, we use morphine for months because morphine is a medication that not only works for pain, but also for shortness of breath. So there are times that folks are on morphine intermittently for months. And even when someone is nearing the end of life, in the hours and the days before, sometimes we have to use morphine when someone is short of breath, because the body, no matter what the disease process, is doing all sorts of things, that affect the lungs, that affect the heart, that we sometimes have to, even if the primary disease isn't the lung, they still can have shortness of breath.
Right.
So, and then if you're, have someone who has aspiration pneumonia or something like that, we want to support the body so it's not struggling as it's doing what it's doing naturally.
So what I'm hearing is morphine is not utilized to speed up the dying process.
No.
How do we handle when somebody is like, well, my loved one years ago, I gave them a dose of this finally, and then they did die, and they did take their last breath.
Yeah, I think going back to what Lauren just said, the body is already dying, and it just happened to coincide with this medication that was given to ease a symptom, and the death occurred. And I think it's such an emotional time. And I think because of the emotions involved in watching your loved one die or dying, it's easy to conflate, that this happened because this happened. And I think, what we do is provide the very best education that we can. Of course, we may not have been involved with the last experience you had, and it colors or informs every other experience you might have, but it's not necessarily accurate. And I think if you're able to put your emotions on a shelf and really look at what symptoms were happening in the days and weeks before your loved one died, they were dying.
I want to share a story that I've not shared with the HD community before, talking about me being an open book, but I think that it's going to help in this instance, talking about this. So when my dad was at the end of his life, and literally just minutes before, well, it was the last night in the hospital. We had a really wonderful nurse who came in, helped with the positioning and all of that. And I had asked her, um, you know, are you able to see signs before it's the last minute? Like, can you tell a timeline? Are you able to see signs? And she said, yes. And I said, okay, well, when you see signs of a change, can you let me know? So that way I can prepare my mother, and because my mother was very emotional at the time. And that night, my dad woke up. He came through the medication, woke up. He was shallow breathing. You could tell that he was in pain. My mom was sleeping, and my aunt was with me, and I saw that my dad was in pain and awake. And I said, Amy, go get the nurse, because I think dad's in pain and he needs his medicine. And when the nurse came in, she had the morphine, but she also looked at me and she said, I see the signs. And I said, okay, thank you. I'll go ahead and wake up my mom. And so she said, do you want me to go ahead and give the pain medicine? I said, yes, give it to him so he's comfortable. And so then I woke up my mom and I said, Mom, you need to wake up. And sorry, it's still hard for me. So woke up mom, and it was definitely dad's last moments. And she's like trying to comfort him and tells him, it's okay if you go, and we're gonna be okay. And my dad passed away at that point. And for years, my mom and I didn't talk about this moment. And my mom thought that the morphine is what killed him, until I told her the full story of waking her up, because the nurse told me she was seeing the signs. Because of course my mom wasn't awake for that, so she didn't know. And so I think that's what people don't realize. Like, you've got trained professionals who see the signs, who can tell you. And it's not that they're giving a shot of morphine and the person is passing away from that. It's they see signs, they can let you know of that and make the person comfortable in that moment so you can have that moment with them. And, I think that's not told enough. Those stories are not told enough, because you're right, so much emotion in the middle of it. And it's like, oh, well, you just gave him a shot, it's got to be that. And it's not. It's they saw the signs.
Yeah, I appreciate you sharing that story, as painful as it is. I think it just speaks to the tornado of what's going on, because sometimes you're also the caregiver. You're the one giving. I mean, your dad died in a hospital setting, but sometimes people are dying at home, and the family is the one administering that little bit of concentrated, and it's not a shot, right? It's
No,
not,
it's
we
not.
call it a shot, and usually there's no needle involved too. But it's a concentrated dose, and sometimes it's the family who's giving it, because
Yeah.
in home settings, majority of the time, I would say 99% of the time, it's the family providing the care to their loved one when they're on hospice services. And so I guess what I'm saying is, forgive yourself for whoever these families are that are out there listening to this, is you didn't do it either. It's you didn't cause your loved one to die
Right.
by giving them what they needed to be comfortable.
Yeah. No,
Um,
you eased a little suffering at the end, so they can, if you can have that moment with them, and even if you can't, it's still just what the body's doing. Like you
Yeah.
said, it is literally the natural dying process, and you're just easing some of the suffering.
yeah. And the aim is to make it peaceful,
Yeah.
to really try and make it easy on the person who's dying and make it peaceful. We're not always successful. I think sometimes, people feel like they're promised a peaceful end, and they feel like we failed when that doesn't happen. But it's, we're not always in control of how a body chooses to die.
Right.
And we're going to do the best we can. We're going to do the best we can to educate the family and support them. We don't always get it right, but this is a big mystery, you know, um, why they're doing this or why they're doing that. We have answers for some of it, but not all of it.
Is it true that to be on hospice, you must, I'm going to switch it up a little bit, but can people, and I would probably, could you explain a little bit more regarding a full code and a do not resuscitate? Can you be on hospice as a full code? Or
You
what does
can.
that conversation look like?
Yeah. So let me first describe what full code is. I mean, I'm a social
Yes.
worker, not a nurse, not a doctor, not a nurse
Yeah.
practitioner.
Yeah.
So layman's terms,
Yeah.
full code in the medical community means when my heart stops, when I stop breathing, do everything humanly possible to try and restart my heart when it has died. It could mean compressions like CPR, resuscitation. It could mean into, like, if you're in the home setting, you would call 911. They would rush and intubate you, possibly with a breathing tube. They would try to find, uh, you know, arteries or veins. I'm not sure which, to put in, things to try to restart your heart. They would maybe shock your heart, compressions, all of it. They have to legally do all of it, to try to restart a heart that has died. And that may mean, carrying you off to the hospital, to the emergency room, so they can continue with the measures that have been started. That's full code. That's what that means. Various states have various language around no code or do not resuscitate or allow natural death. All of that is the same, and it means when the body is naturally doing what it's trying to do, and that is to die, just let me go as peacefully as I can be let go. Give me, DNR, no code, allow natural death. It doesn't mean don't do anything to support me. It means give me medication to ease my suffering as I'm going. So that's the difference between full code and do not resuscitate or do not, or DNR. In our hospice, every hospice may be different, but in our hospice, you can be full code and be on hospice services. Our aim is to, what we realize is that certain medical practices or clinics or practitioners may not be comfortable having this conversation with the patient or their loved one. And so we do get folks who come to us as a full code because no one has had the conversation with them before they get to us. And our goal is to provide education about the do not resuscitate decision. I know it's a medical decision, but I think it's an emotional one, because for some people, it feels like I'm giving up.
Yeah.
Or I'm giving up on my loved one. Um, I and that's for me as a social worker where I always approach the conversation from is, tell me what you think about when you think about making this decision to be a do not resuscitate. And the form is scary too. It's a bright orange form with a stop sign. Legally, you have to have that in the home or in the facility to avoid a code. Because if you don't have it, paramedics or EMTs are required to start resuscitation efforts. So if your loved one, you or your loved one are choosing to be do not resuscitate, it's really important to get a form like that in place. Otherwise, they legally cannot, you can't stand over your husband or your brother and say, don't do this. They legally have to unless you have that form. So that form is so important to have with you in your place of care, to have it honored. But yeah, I think hospice palliative care, we are our training, our goal is to really help you understand why resuscitation is not, it doesn't save a person. And the reason I say that is because usually with most diseases, your heart is stopping because the disease is progressing, because it has reached that very end point where the person is dying or has died. And the heart is the last thing to stop, right? The breathing, the lungs, the heart, it's stopping because your disease has reached a point where you're dying. And resuscitating someone or trying to resuscitate someone, because the statistics are not that great about restarting a heart that has died when you have an end stage illness, it doesn't take away the reason why it happened, why the heart stopped. If you have a terminal cancer, or if you have HD, your heart is stopping because your disease has reached that point. So trying to resuscitate it doesn't take away the cancer. It doesn't take away the HD. I hope that made sense.
It does make perfect sense.
Yeah.
I think what a lot of people don't realize, and it's actually been new research, is that HD does affect the heart. And so, at the very end with Dad, I did not know that actually was part of HD, his heart giving out like that, or stopping, basically, is what it slowed down and it stopped. And so, but yeah, I mean, like you just said, that's just part of the disease process in the end, and something we should know.
I want to reflect on what you talked about with just statistically, and how you know resuscitation is a trauma to the body. It is, there's sometimes there can be, if there can be broken bones, there can be fractures, there could be, am I correct? There could be some additional issues that are having to be now dealt with or waiting to heal after a resuscitative effort.
So I once had a doctor tell me that, Shivani, if we resuscitated you, and I, don't have any of those diseases, I am a healthy 40-something-year-old, you would have broken ribs, and you would have maybe a punctured lung because of those ribs. So when you're talking about potentially resuscitating someone who has, lost a lot of weight and their bones are fragile, that could do so much more damage to someone who's already dying. And I think you use that word trauma. It is trauma to the body, the Resuscitation Act. it's also trauma to the family. It's trauma to the person who may be resuscitating, if it's a paramedic, if it's a nurse, if it's an aide. I think we don't always think about the trauma, you know, to all of the others when resuscitation is a futile resuscitation is attempted.
And this is a difficult conversation to kind of start early on, right? We're all technically walking full coats.
Hmm.
Like we are, if something were to happen in any shape or form right now without that document, we are to be resuscitated. And that's, you see in the movies, like somebody drowned, resuscitation. And that's just, I mean, you just kind of get that idea of like, that is the natural way of things. And when we're talking about end of life, when we're talking about illness, that is not always the reality of getting that spontaneous, oh, well, glad this happened and now I'm back to being me.
And
There
nothing
can be a
happens and
lot
you can
more,
stand up and walk off a beach and yeah.
right? There can be
Yeah.
so much more to deal with.
Yeah. And I think
That's involved with that.
watching things on TV, I think, has really hurt this conversation.
Yeah.
Because it does. Yeah. People get, and then the next scene is, them waking up to talk to you when in reality, your loved one may be in uh, a coma, intubated in an ICU. And I think for the patient, if you're able, the person with the disease, if you're able to help your family by going ahead and making some of these decisions so that they don't have to, I think there is trauma also in being the family member that has to say to the doctor, the medical team at a hospital setting, when someone is on life support, please stop life support. It's such emotional trauma to carry, you know, for your family. Yeah. To have to choose to stop something than to never have started it in the first place.
Is there a form or documents that should be kind of in place that helps maybe facilitate that conversation or at least get something in order to help express their desires to their loved ones?
Yeah, there's all sorts of forms. So the
I know,
yellow
state to state.
do not, yes, exactly, state to state, maybe even country to country.
Mhm.
The do not resuscitate form is the form here in North Carolina. There are other forms like the most form, which is the hot pink form. I forget exactly what it stands for. But it also speaks to more specific decisions like antibiotics, IV fluids, uh, and resuscitation.
Mhm.
Then there are advanced care directives like healthcare power of attorney or a living will. And it's important to note that having a healthcare power of attorney done or a living will is not equal to a do not resuscitate. So, the paramedic isn't going to stop and say, let me read through these 5 pages to look at what your decision would have been. I think that the healthcare power of attorney allows you to choose who would be my decision maker if I couldn't make these decisions myself. And I think it's important to have, these documents completed, but even more important to talk to your family to say, under these circumstances, I wouldn't want X, Y, and Z. It having the form completed, but then choosing a person who wouldn't
And not
follow
have that. Mhm.
your instructions is like, then there's no power in the form.
Mhm.
And a living will doesn't actually talk about your 68 Chevy or whatever. It's about, do I want, when I have a terminal condition and I'm dying, do I want IV fluids? Do I want to be fed by tube? a peg tube or a feeding tube. So that's what that form covers. And I'll just say one more thing about the forms, the healthcare power of attorney, the living will. A person has to be completely alert and oriented to complete them.
Yeah.
So there comes to a point where it's too late to complete them.
Yeah.
Because they don't have the cognition or the mentation, the alertness or the orientation to be able to complete them because it's a legal document. So tube feedings and IV fluids it's a topic, a question we get all of the time in hospice, probably in palliative care as well, because people, I think we show people that we love them by feeding them. I think across many cultures, that's how we show them, I love you. Here's a piece of cake. And I think it is counterintuitive to think about the dying process actually being harmed by IV fluids and tube feeding. Because when a person is not able to swallow anymore, that's their body naturally saying, I don't need all this. I don't need the drink. I don't need the nutrition. My body is trying to let go. It's trying to begin that shutting down process. And sometimes we humans can get in the way by introducing medical interventions like inserting a feeding tube. It's kind of bypassing that whole swallowing mechanism and kind of forcing the body to take in nutrition when it doesn't really want to. It doesn't know what to do with it. Sometimes we can see that people who have a feeding tube or G tube, as it's also called, they can still have aspiration, which typically we think of aspiration swallowing incorrectly, but it can also kind of from the bottom up, stomach up. It can also go the liquids or the whatever the feeding is. It can go into the lungs in that way too, and cause an infection or cause pneumonia. And studies, there have been studies that have been done that show that when a person is no longer eating or drinking on their own, they're not starving in the traditional sense of like, if we stopped eating at this point right now, we would be starving, but our body kind of knows how to protect itself from feeling suffering. And it releases endorphins, masking the feeling of hunger at that point when it can no longer take in something naturally. And IV hydration, we do things in hospice to make sure someone's mouth is a mouth care to make it so that it's not dry, the mouth. But introducing IV fluids when someone isn't drinking naturally, it can actually cause more pain because the body is saying, I don't know what to do with all this liquid. We don't do it in hospice. We don't have IV fluids in hospice care at home or in the hospice center because it causes harm. It causes pain and discomfort because our kidneys are beginning to shut down. It can't process the liquid that's being injected or dripped. It can cause trouble with breathing. It can cause fluid in what they call third space, which kind of it doesn't know where to do it. So you might just see more bloating in the central cavity, or even in the legs and the arms. So it's actually more comfortable to die when you're dying of a terminal illness. It's more comfortable to be dehydrated, I guess, for lack of a better word.
I have a question about oxygen.
Mhm.
So I know sometimes, especially with those with COPD, they're given oxygen at end of life for comfort purposes. But could it also cause issues at the end as far as, I don't know, prolonging things or anything like that, or masking things?
Yeah, we think of oxygen as a comfort measure.
Okay.
It's not traditionally seen as something that is um, keeping someone from dying. I've seen lots of folks use oxygen at the end of, or have oxygen placed on them, but their mouth is open.
Yeah.
So, they're not really getting the level of oxygen that you would think, because even though it's going in the nose, it's not really being absorbed that way. But we think of it as a comfort measure. Sometimes it eases shortness of breath. Sometimes, if a person is really agitated at the end of life with that terminal agitation, they're not going to keep it on. So we don't tend to want to fight that. The body, they're obviously saying, don't put this on me. We just leave it off. So it's not a, you have to have it or you don't have to have it. It's just, is it comfort? Is it comforting for the person to wear it at this point?
So it's not harmful, like what you're talking about with the fluids, which makes perfect sense, right? Like if everything's down and your body can't get control and start going in places you don't want. So that makes sense, but not the same for oxygen.
Mm-mm.
Okay.
No.
I mean, Shivani, of course, you're explaining everything just so beautifully, but it's this idea of like we're really trying to be in tune with our bodies, and hospice care, as professionals, you are trying to help families process and help their loved one be in tune with their bodies at a natural dying stage. Do families still have do people still have a bit of control if you're educating one way and they're going, I still want to get IV fluids, I still want to do this? Can they hop right off hospice and I guess go do what they want to do?
They can. There's no once someone has signed on to hospice, it doesn't mean that we are, um, going to hold you hostage. If you want something that is more curative or aggressive, people are welcome to revoke hospice services to be able to uh, go to the hospital or get treatment of any type. We just, there are some lines in the sand, like IV fluids or um, chemo or things like that, that we just don't, that aren't part of our philosophy and we don't cover. So people can sign off of hospice, get whatever treatment that they want to have. If they are aligned with the hospice philosophy, again, they can come back on hospice, be evaluated to come back on hospice. So it's not a permanent decision in any way. And I think, there are times where, despite all of the education that we and support we provide, people just don't want to give their loved one this medication or that medication. And we're not going to force someone to give something that they don't want to give. It's hard to watch because that means that the person might be dying uncomfortably. They're still dying. That's still happening. They're just, there's a higher chance for suffering to happen while that's happening. So
I wanted to point out, and I don't know if this is for every hospice, but I wanted to point out something else that seems pretty beneficial to families, at least with the company that we've used for Papa, and that's the grief counseling for families. And um, I just think it's great that that's offered as well, through all of this, and to be able to get that grief counseling for free.
yes,
We offer it
yes.
for free.
So with our hospice organization transitions, we do have a grief center, and it does serve folks who have been on our hospice services, the families of those folks who've been on our services. And these are trained bereavement counselors, and they provide tremendous support. And I think just a soft place to be able to process all that's happened. We tend a lot of people are like, well, I need bereavement immediately. Like I need it the week after my loved one has died. We've found that you don't really know what you need when someone has died. And in fact, uh, a lot of folks tell us that the first few weeks after someone has died is just they're in shock. They don't. There's so much to attend to when someone has died. That the funeral service or the cremation service, all the business that has to be taken care of after someone dies. You need time. And usually folks engage in grief counseling about a month or so after, when things get a little more quiet. But we do
Have you ever seen people do it before their loved one has died, like the dealing with the anticipatory grief?
Yeah. So we, not in our grief center, that's for bereaved, but our social workers certainly do provide emotional support around anticipatory grief um, while they're visiting their uh, the patients and the families, in the home setting or the facility setting, wherever. And sometimes people want more. Uh, People want more intensive counseling, and so we would encourage them to seek out like an outside counselor whose focus or specialty is on grief counseling, so that they can get additional support beyond what the hospice social worker or spiritual care counselor is providing.
Um, for somebody who has significant psychiatric needs,
Mhm.
what kind of does the hospice team help do some type of safety planning if there is maybe prior or current like suicidal ideation, maybe threatening of going, I'm just not going to eat, like, or I'm going to do XYZ? What does that kind of look like when the team is notified of that?
Yeah. So sometimes we know that before someone is admitted to hospice services. Maybe they've had prior suicide attempts via medications, like
Mhm.
overdosing or taking uh, medications. And we try very hard to, while honoring a person's agency, um, wanting to make sure the medications are kept safe and prescribing enough medications to manage the symptom, but not, you know, eh, not sort of aiding in giving you all that you need to possibly carry through a plan.
Mhm.
We partner with mobile crisis sometimes to uh, give the patient, or sometimes even the caregiver, additional resources to be able to manage feelings um, around the the grief, that the anticipatory grief, or the feelings of hopelessness and all of those things. We try, when we have folks who are struggling, we increase our visit frequency to try and manage or support feelings around some of the things folks are facing. Um, we contract with them that they will not harm themselves in this way or that way. Um, we're not able to control everything. Um, and I think, we hope that our families will partner with us in trying to keep someone safe. Yeah.
This has been an incredible conversation, and I can't thank you enough, Shivani, for providing all this information. And I know that we could probably talk a lot longer on this, but I
Mhm.
just wanted to
Mhm.
thank you because um, it's not a discussion that I think most of the families have had, right? And so it's so good recorded and be able to share it with our community to answer some questions.
Absolutely. And anyone can call into a hospice. You don't have to go through a physician to get a referral to hospice. You can call and say, my husband is experiencing these symptoms. I would like for him to be evaluated. And we'll get the orders and all after. But if you want to initiate a call, you don't have to go through your doctor initially.
Interesting. I didn't know that either. So that's
Mhm.
very
Well,
cool.
before we look at like really close it up, how would somebody go about like finding the right hospice for them? Like, are there some things that they should consider or think about when they're making these calls, or if they want to reach out to a few hospices in their local area?
Absolutely. So there, most areas have multiple hospice agencies. Um, I think one you can go on the nhpco.com website to find a hospice agency in your area. Transitions Life Care is a nonprofit hospice. It was founded 40 plus years ago as a nonprofit, and we've maintained that status. And I think it enables us to provide care and support to folks without, we get folks who don't have any insurance. Like, we'll never turn you away because you don't have the right insurance or the insurance or a insurance. Um, and I think that's an important part of our mission because we want folks to have a dignified um, end and quality of life while that is happening.
That's a, that's a great point where it's, there are for profits and there are nonprofits, and to make sure you kind of uh, look into that difference of coverage of, if you don't have insurance. That's how essentially hospice is funded. It's
Mhm.
Medicare, it's Medicaid, it might be a private insurance, but it's also fundraising and it's donations.
That's
And
right.
with nonprofits, that the philosophy is more the structure feeds back into the community.
Yeah.
That's right. Yeah.
Not all hospice agencies are the same.
Mhm.
And so absolutely do your research in that area, because it's true. Like, you want to have the one that's going to work so closely to your own, philosophy of that, and show that care. And um, so yeah, doing that research I think is huge.
And spiritual care touches on every type of uh, beliefs. I hate to bring this up towards the end. I'm like, I know we're like,
No, you're
but
good. I just
I'm like,
wanted to
no,
make
you were
sure, like,
tying
I
it up
wanted to
so
thank you.
beautifully.
So
No, you're tying it up so beautifully, and I'm like, oh, well, spirituality and spiritual support. When, especially if it's not, if it's not strictly one belief, maybe it's they don't have a belief system. Can spiritual support still support everybody?
Absolutely. Our spiritual care counselors, there's a reason we don't call them chaplains, because they are trained, to really support someone without regard to, like, I'm of this denomination or this religion. Sometimes it's, I have this life philosophy, and I want to talk to someone um, uh, who can support me in, all this existential crisis I might be having. Our spiritual care counselors are not um, part of any denomination, and that's how they're able to support anyone, regardless of their belief systems.
Thank you, Shivani. I'm like, I feel like that's, I hope everybody who's watching this has been able to get a greater and more abundant information just around hospice, around the philosophy of care, around these human beings who love and enjoy what they do, to get you and your loved ones in touch with what the body is going through. And death and dying
Truly.
is not something that, you know, we want to talk about necessarily, but
hospice is truly a
needs to
phenomenal
be.
resource, and just it truly has been an incredible discussion, just showing that resource, not only for our community. I think there's this gap of education on this, which is why we're doing this. um, but just in general, this is just such good information for anybody to have,
Yeah.
in looking for resources.
I want to say one final thing before we end, and
Mhm.
that's to encourage families not to wait to engage hospice.
Mm.
I think, you know, we as hospice team members, we want to get to know your loved one. We want to get to know you. And you know, the I think the best circumstance is when you give us a few months with you. Give us a few months to really support you, to really provide that education. Of course, we're going to provide care and support when, you know, if your loved one we think has a few days left. But let us call us in early enough that we can really hold you and support you and um, and get you as ready as one can be.
Beautifully said. If anybody watching this has any questions for Shivani, please reach out to us. You can go to our website at hdreach.org. You can send me an email. I'll put it towards the end of this video. But we thank you for being a part of this. And Shivani, thank you so much for providing your wisdom. And I hope everyone has a wonderful day.
Yes.
Thanks for watching.
Take care.
Thank you.